Hello, hi everyone. Welcome to our multimodality imaging lecture series. It's a great pleasure today to have Dr. Matthew Martinez that will be talking about imaging in athletes to how to differentiate between pathology and physiology. Dr. Martinez is the director of the sports cardiology program at Morristown Medical Center. He's also the co-director of the Hypertrophic Cardiomyopathy Center, and he did all his training in Mayo Clinic, med school, residency, fellowship. He's currently a world-renowned cardiologist for sports medicine. He's the leading cardiologist for the Major League Soccer and as well as for the New York Jets, and he also works with players from the NBA. So it's a great pleasure to have you here today. Thank you so much for being here.
Thank you for the introduction. Thanks for inviting me. I am excited to talk to you about this topic that continues to grow within, I think, the sports medicine community, within cardiology. And I think we're seeing more and more folks realize that there is a lot going on within the heart of the athlete, not just the bones. So we're going to talk about how we differentiate pathology from physiology. I'm a clinical cardiologist. I see patients 60% of the time in the office. The other 40% of the time I'm doing imaging. And as part of that, I do hypertrophic cardiomyopathy and other diseases that cause risk for sudden death. And that's sort of what melded into the sports cardiology program. So here are the teams and the organizations I work with. I did advise Bristol Myers Squibb and will eventually help Cytokinetics with their rollout of the new drug. They'll have no impact on this study, on this discussion, but I include it just in case people are aware that I don't want them to think I'm hiding anything. So when we think about the athlete's heart, we think about it as either an electrical or a structural change. So in the electrical realm, pretty common, right? We know ECGs are abnormal. A lot of times abnormal compared to athletes with bradycardia, voltage changes, repolarization changes, and even T-wave inversions that are a result of the structural changes underneath. The increased cavity size, increased wall thickness, both the atria and the ventricle, and they all do that as a physiologic adaptation. The more athletic you are, the type of sport you play alters what the ECG and the echo look like. But there's overlap between pathologic findings that make athletes somewhat at risk to be overdiagnosed with conditions they don't have. So when you think about athletic cardiac remodeling, we typically break it into one of two categories, and there's clearly some mix that occurs, especially in today's modern athlete. But think about it as like those that are endurance athletes. They have increased cardiac output 4 to 5 times above what their rest is. They can do this for hours on end. Maximum heart rates, increased stroke volume, and the vasodilatation that comes with that is a volume challenge. Much like we see with severe aortic insufficiency, the ventricles dilate as a result. If you're a strength athlete, you've got repetitive increased systolic blood pressures, skeletal muscle contraction, and that vasoconstriction somewhat mimics what you see with aortic stenosis, and we refer to that as a pressure challenge. So depending on the type of athlete you are, that can your adaptation can be a physiologic difference. So if you look at NFL athletes, this was data from the NFL from 2013. I think we showed this abstract where we found that unlike traditional descriptions, athletes can sometimes have 10% of the time 13, 14, 15 millimeter thick ventricles, well beyond cutoffs for the ASE. We saw the same in the NBA data, 2013 through 15, in that gray zone, 13, 14 millimeter, about 10% of the time. But the ventricles also were dilated. This is, again, the NBA data, about a third, with ventricular size 60 millimeters and bigger. These were normal athletes, with the majority of them having ejection fractions above 50%, occasionally dipping below that, all normal physiologic adaptations. But if you use standard cutoffs, you're going to be well above what, quote, normal looks like. We looked at US soccer athletes. This is from Churchill in 2021. If you use ASE cutoffs, about a third of women above the upper limit of normal, 40% of men, and still, again, that percentage into that gray area, but less common in women compared to men. So that's important. Not only the type of sport, but your sex will have impact on that. They looked at LV wall thickness and diastolic volume index and LV mass index. And based on your age, your sex, all of those can be abnormal, quote, abnormal compared to what we normally think of. Old data in 2004 showed the same, but really extreme in these cyclists. About 60% had diameters, about 50% had diameters over 60 millimeters, and many had ejection fractions in that 45 to 50% range. So depending on who you are, what you do, and your ethnicity, all of that can impact what we consider normal. And these are physiologic changes. And the stroke volume is the key. So we know that the heart rates are often lower, and they compensate for elevated stroke volumes. Athletes typically have much higher stroke volumes compared to control groups. Most of the athletes I'm seeing are in the 120 range, well above what you would consider normal, but their ejection fractions are largely unchanged from others. Most have an EF between 55 and 65%. So the ejection fraction can't help you. It's the stroke volume, it's the size and the thickness that really matters. So if we think about athlete cardiac remodeling from the left side, left chamber dilatation can occur with hypertrophy. It can be eccentric or concentric. You can have a normal LV chamber size, and the ventricle can be non-dilated. You can have concentric or eccentric in that group as well, or the left chamber can be dilated, as I mentioned, with concentric hypertrophy. So the ventricle could be big with or without hypertrophy, or normal sized with concentric hypertrophy, just based on what type of athlete they are. RV chamber enlargement can also be increased, but overestimated, again, based on ASE criteria. This is 2012 data from Oxborough. And whether you use the cutoffs from the ASE for the RV inflow or the outflow, somewhere between 40 and 60% of the time, athletes will be considered abnormal, falling into that pathologic finding if you use standard cutoffs. So if you put it all together, whether it's the left side or the right side, you can see with or without dilatation, with or without thickening, or left side or right side alone, many are going to fall into this gray zone. And our job is to distinguish between the pathologic findings that also do that: valvular heart disease, dilated cardiomyopathy, left-sided cardiomyopathies, or right-sided cardiomyopathies. So there really isn't a perfect way to do this. It really requires a comprehensive assessment of the athlete, talking about who they are, where they're from, who their parents were, what type of sport they participate in, what sex are they, a comprehensive physical and an ECG to see if they have physiologic adaptations of the ECG, and sometimes a treadmill exercise test to help us distinguish it. We'll talk all about that, because the determinants of the athlete's heart are not singular, and neither are the tests that we use to evaluate them. All of these pieces of the puzzle go into whether or not this is a physiologic adaptation or not. But like in most scenarios for cardiology, it all starts with an echo. So whether or not you're using 2D or M mode to evaluate wall thickness, clearly a wall thickness under 15 millimeters with a ventricle that's normal size or increased is what we would expect in the physiologic adaptation range. Virtually never is the wall thickness normally above 15 millimeters. Rare exceptions have been shown, but if you look at the emerging data and the published data that's now present, we know that the vast majority are under 12, a few are in the 13, 14 millimeter range, and virtually none are over 15, and they all have normal or increased diameter changes. If the ventricle is smaller, if there's a decreased ventricular chamber size, especially under 45 millimeters, this is a predictor for hypertrophic cardiomyopathy. So 14, 15 millimeter thick with a ventricle that's smaller that would really favor hypertrophic cardiomyopathy. Diastolic function is important in the athlete, and when normal can be very, very reassuring, whether it's transmitral Doppler or E prime velocities with tissue Doppler indices. You can see here, these are all endurance athletes, pre-training and post-training. All the diastolic parameters were normal. When they looked at the NBA data, normal diastolic function with an average E prime under 5 in all of those NBA athletes, despite a little bit of thickness, about a third with those giant ventricles, and normal ejection fractions in nearly all. Strain imaging can absolutely help. We would expect it to be normal, very normal in the endurance athlete, minus 22, 23, 25. In the strength athletes, we often see the strain dip into that minus 18, 19 range, but still expected to be normal. And then contrast that, of course, to septal changes like you see here in hypertrophic cardiomyopathy, or if there's apical sparing with amyloid can overlap with this, and that blueberry pattern for apical hypertrophic cardiomyopathy. So we would expect in the athlete it to be normal. When it's abnormal, I would encourage you to go back and make sure that it was done correctly, make sure that the tracking was done well. As an isolated finding, I would not rely on strain, certainly to call something a cardiomyopathy or to disqualify somebody. In the setting of a normal medial E prime velocity, an abnormal strain as a standalone finding may or may not be helpful, and many times you may end up having to throw it out. So here's an example of a 17-year-old soccer player. And his trainer said, look, something's not right. He just isn't progressing like everyone else. He is more and more breathless with each week we go on. He hasn't passed out, no family history of sudden death or cardiomyopathies. And here was his ECG. So nothing terribly critical there, nothing that jumps off the page at you. There are some minor findings that they should have identified. Went on to echo. Here's both the short axis across the top, parasternal long, clearly nothing abnormal here that's jumping off the page. Diastolic inflow was normal, but boy, his medial E prime velocity was a little less than I would have liked it to be for a young athlete, 995. I'm sure if you asked those who are seeing professional athletes, we're typically in the 12, 13, 15 range. So 9 stood out for me. Then the strain value, you can notice, was abnormal, especially in that septum. Global strain, which I think can steer you astray for sure, minus 22%, although most reproducible, you can see that differential reduction in the septal wall. So then what's the next step? I told you that, it's putting it all together, right? Nothing. He needs a stress echo. Let's go back to the echo with contrast. What about a coronary CT or how about a cardiac MRI? Now, in this case, we moved him on to MRI when he came to see me for further assessment, and it became very clear what was going on with the MRI. Clearly, there is increased wall thickness in the septum, in the inferior septum, much like we thought might be happening with those strain values. So putting all of those pieces together, despite the echo really not showing us the degree of hypertrophy we saw here, we thought he had hypertrophic cardiomyopathy. So when you think about the cardiac arrest etiologies, whether it's left-sided, coronary arteries, right-sided disease, aortic disease, or valvular heart disease, really cardiac MRI identifies more than 90% of them. Now, I'm not suggesting that we use this as uniform screening for athletes. This is something that Ben Levine and I published in 2017 when they asked us both to separately comment, and we both came to the same conclusion, that it's a really important test. It's a powerful test, but not really well utilized for asymptomatic screening because of the technical aspects, the availability, the expense, and the expertise in not only obtaining the images, but the expertise in interpreting the images. So how the images are obtained impact how the reader can interpret them, and then understanding the physiology that goes underneath that can lead to challenges and can often lead to athletes being harmed. Now, cardiac MRI, I think about at least in this realm, as coming in one of these three pieces. We'll talk about still images in a minute and whether it's scar or morphology or edema. But cine images, morphology, and function are really the workhorse of cardiac MRI. And the functional analysis for MRI is really unmatched. It is the reference standard for LV ejection fractions, for mass, for wall motion, for right-sided stroke volume, for volumes on the right side and the left side, and really has become an important way we evaluate cardiovascular disease as a whole, but clearly in athletes as well. Because as we know, echo can both under and overestimate hypertrophy compared to cardiac MRI. And in terms of underestimations, it struggles just from its acoustic ability to look at the heart using ultrasound. It struggles, especially in hypertrophic cardiomyopathy, in the apex, the interventricular septal posterior wall, and in that basal anterolateral free wall, just like we saw in our prior athlete. And in those with non-contiguous LVH, you may have mild hypertrophy in one area, but not another. So here's an anterolateral LV free wall shown by echo and well underestimated compared to what we found by cardiac MRI. Published data from Dr. Marin on that. The posterior septum here we saw in our last case, the same phenomenon where we struggled over this asterisk. It becomes crystal clear with the cardiac MRI. And non-contiguous patterns look like this. So if we have a long axis view by echo, it may miss hypertrophy on either side of a normal wall thickness, making it difficult to make the diagnosis. So whatever the sonographer shows you is what you're going to interpret. We know well in apical hypertrophic cardiomyopathy, the echo can often underestimate compared to cardiac MRI. This ended up being nearly 20 millimeters, but we suspected that based on the T-wave inversions by the ECG. So putting it all together, deep T-wave inversions with ST depressions all the way out through V6, high index of suspicion, international criteria very clear about this group. You got to be worried about it. Additional investigation is going to be required. So if you see that ECG and the echo doesn't help you, should really have a low threshold to pull the trigger on cardiac MRI. So the international criteria went further in this last version compared to prior renditions. And it said in those T-wave inversions in the lateral and the infralateral leads, cardiac MRI should be routine. It should be the best way we evaluate apical HCM, the degree of hypertrophy, and even looking for other things like ARVC as a potential culprit in this group. So a low threshold for cardiac MRI in that ECG setting. It can also overestimate. There are some challenges when they're looking at echo and you're measuring depending on the individual. Sometimes when we do this at the NFL Combine and the football players for the Jets, they're huge and their ability to measure the wall thickness can be challenging, and you can overestimate looking at the Crista Supraventricularis here, or sometimes there's some LV insertion papillary muscles that are normal findings, but that can lead to erroneous measurements of the wall thickness. Marked difference 23 to 34 completely changes the management in this group, taking them out of ICD range and into an entirely different risk category. So in 2021, we saw this by echo data, comparing it, looking at basal, midventricular, and apical measurements, and there was quite a bit of variation. Here's an example of an athlete that came to me, quote, disqualified for a wall thickness of 1.6. But you can see they absolutely overmeasured it. We remeasured it at 1.1, a normal LV wall thickness. We confirmed that by cardiac MRI. Again, overestimation of the wall thickness utilizing echo. MRI in a single test without contrast, you well know, can evaluate the aorta. It can confirm or diagnose bicuspid aortic valve, and it's my first stop for anomalous coronary arteries. CT is clearly better than MRI, but if I can avoid the radiation exposure in a young individual to exclude coronary artery anomalies, I use MRI first. On occasion, it's very clear and I don't need the CT, but if I find something suspicious by MRI, I can at least cull down that group that I'm radiating and go on to CT from there. But what about the still images? What about late gadolinium enhancement and scar? It's a big part of how we practice cardiovascular disease now. This group knows well images obtained 10 to 15 minutes later. We're both using 1.5 and 3T in our institution for cardiac studies, and obviously looking for necrosis or that scar tissue. And the pattern helps, right? We know that it can help you with infarction, both subendocardial and transmural, but it can help with apical aneurysms and scar formation for hypertrophic cardiomyopathy, or in the septum and risk stratifying them, making a diagnosis of myocarditis, or in someone with a big ventricle that you're not quite sure is physiologic. That scar tissue in the septum can be very reassuring that this is a truly pathologic finding compared to a physiologic finding. So exercise has been described in the remodeling, as we've talked about, both the right ventricle, the left ventricle, and ECG changes. It's also been indicted in elevations in troponin and coronary disease, and I'm going to save that for another day. We don't have time for all of that, but clearly fibrosis is what's come up absolutely in the last year. Most of it started in 2012 when Dr. LaGersh, really smart cardiologist from Australia, started to find these incidental fibrosis in the septal, as you see there. And he proposed that this was related to the strain that occurs post-race and the pressure that occurs with the right ventricle getting bigger as a result of the physiologic adaptation. And they found abnormal strain values radially that correlated to that same area of fibrosis. No true mechanism for that, unknown. Was it pulmonary hypertension, quote, RV strain, as we described? But I wasn't seeing it a lot. We just weren't seeing it in most athletes, especially young athletes, sometimes in that older group. And Levine helped sort through this in 2016 when he looked at groups from the Cooper Center for Longitudinal Study, and he broke them into groups that were mostly sedentary in group 1, all the way up to this group 4, which was 6 to 7 days of exercise per week plus competitions. No risk factors, no known coronary artery disease. And what they found based on the group was that very few changes. They had an increase in LV mass, they had a change in end diastolic volume, and appropriately their stroke volumes were different the more athletic they were as you moved on to group 4. But they didn't find late gadolinium enhancement, which I think is really important to identify. This was an older group as well. And what they concluded was that lifelong physical activity, regardless of the amount, was not associated with myocardial fibrosis. Further study from Thijs Ijsvogels overseas looked at this large meta-analysis, and what he described in all of these studies, he put all of this together for us. About 6% of the time, you're going to find cardiac MRI fibrosis, and it was mostly in older athletes. And in this group, many of them were acute, meaning they came right off the race and then went into the MRI scanner to look for those scar findings. But if you look at the younger group, 40 and below, you can see that absence of scar was actually more the norm. Less than 1% had cardiac MRI. And as I mentioned, 5 of those 7 were those that came right off the race and onto that. So the absence of scar is really powerful in helping to determine if this is a pathologic finding or not. Here's a 19-year-old sprinter sent to me for asymptomatic normal ECG. They did a screening echo. They found no prior medical history for him, no family history of sudden death or cardiomyopathies, but his LV function was a little low, normal diastolic function, elevated stroke volume, and they weren't sure if this was physiologic or pathologic, and they actually called it non-compaction. They looked at the apex here and said the ventricle's dilated, LVEF's a little bit low. We think this is non-compaction. So this has been controversial, and Eugene Chung, who's the current chair, really started to talk about this over the last 5 years. And we were concerned about over-restricting individuals. And then Sanjay Sharma in 2013 published this really important data that's helped me sort through these with highly trained athletes. And he proposed perhaps we need a better way to evaluate athletes. He looked at almost 1,250, most of them men, although a third were still women. and 8% of them met criteria for non-compaction. You can see compared to those with non-compaction and those without non-compaction, there was very little difference in LV and diastolic diameter. The function was the same. The diastolic septal velocities and the lateral velocities were also very similar between the groups. So he dug into this a little bit deeper and looked at those 8% and separated them into Black athletes and non-Black athletes. And he found that of them, a smaller portion had T-wave inversions. And of those with T-wave inversions, those are the ones where the ejection fractions went down. So if you looked at those 10, end diastolic dimensions were clearly bigger in that group. The ejection fractions were in that 48 to 50% range, and all of the diastolic function was normal. Importantly, they had follow-up, almost 5 years worth of follow-up and no adverse events in this entire group. And what they proposed was that the athlete's cavity dilates, as we talked about earlier, as part of a preload condition, that it was really more of an epiphenomenon. And in those with an increased preload for whatever reason, in this case, the athlete, if the ECG was normal, this was most likely a physiologic adaptation. And he actually looked at this in pregnant women and said that if the ventricle is normal size in the first trimester, as you get towards the end of pregnancy, because of the increased volume, you can actually see non-compaction in this group as well. And then they are cured. They are cured with delivery and on normalization of preload after the baby is delivered. The ventricle returns to normal and the non-compaction goes away. But he did say that this deep T-wave inversion group with that mild reduction in LV function, that's the group you ought to spend a little more time on sorting out if they have increased risk or not. And he said, we now conclude that dilated chambers and trabeculations are often encountered in athletes. Much like we saw with physiologic adaptations, those trabeculations are really common. It's a normal response of the preloaded heart. But perhaps cardiac MRI can help identify helpful features that may sort this out. So if you look at the MRI diagnostic criteria for non-compaction, in most studies who look at this, they're going to use the Peterson criteria compared to the other proposed criteria. And if you look all the way back at that paper, you can see that they used a whopping 7 patients to come up with a criteria for LV non-compaction. So careful with the data. And they proposed using cardiac MRI, using a diastolic non-compacted to compacted myocardium of over 2.3. Here's an actual patient of mine with non-compaction, known non-compaction, prior small stroke, VT, ended up with transplant, and prior to that, significant scar was predicted. So we were able to get ahead of this by saying they're at higher risk. We got a little more aggressive. They were clearly not athletic changes, clearly non-compaction. So maybe the presence of scar was the separation of why that last group from Sharma did so well. So I went back to the paper and I pulled the data, and indeed they used Peterson criteria for non-compaction. So that 7 patients helped guide them in making the diagnosis of non-compaction. And none of the patients that they included had late enhancement. They were all asymptomatic and had no adverse events. So perhaps we should be adding to that TWI group with associated possible non-compaction that cardiac MRI should be part of the evaluation, and that the presence of scar is really helpful. So is this physiologic or pathologic? Not non-compaction. They went on to be cleared, but I did use cardiac MRI, which confirmed the wall thickness. It confirmed this trabeculated area. It confirmed that low normal ejection fraction and the absence of scar. But then I went a little bit further. We said that in this individual with preserved diastolic function, who I thought was an athlete, I needed a separator. I needed something to tell me that they were truly at lower risk, and I put them on a treadmill. So we CPET'd them. We looked at their O2 pulse. We wanted to see what their functional capacity was, and we did an echo post, and we found with intervals, with a high VO2, 17 minutes on the treadmill, no arrhythmias, and normal augmentation of the ventricle. So in that group where you find dilated chambers and trabeculations, expect that this is a common phenomenon in athletes. You should expect normal ejection fractions of the majority, elevated stroke volumes, normal diastolic function, and the absence of scar. And this is almost certainly a preload phenomenon related to just being an elite level athlete. But in those that have suspected non-compaction, exclude the high-risk features and look for disease. If you have abnormal diastology, abnormal strain, or an MRI with scar, that's a group that you may have to be more thoughtful about and concerned about. Maybe as closer follow-up. It may not necessarily be disqualification, but it is important that this is the group we can cull down to using MRI and stress testing. All right, what about morphology and edema? I'll keep this part quick because most of the data is on the diseases you see here. Extracellular volume and T1 and T2 became very popular in the last few years, where we saw a lot of it occur with post-COVID. And the challenge with that is that there's clear separation between AL amyloid and HCM and normals, but there's quite a bit of overlap between HCM, DCM, and normal values as well. So I'm a little reluctant to utilize this, and this is why. In the asymptomatic athlete, utilizing this criteria led us astray in the last year or so during COVID with advising athletes. And it started with this group who published early on because we were all nervous about it. And when they looked at abnormal MR in about almost 60% of athletes, 40% had pericardial involvement with effusions or pericardial enhancement, and they didn't have myocardial inflammation. That was the complete opposite in the next group that showed about 50% had abnormal late gadolinium enhancement, some with T2 findings, the majority without T2 findings. Pericardial effusions were unusual but present, and 15%, or 1 in 6, met criteria for Lake Louise criteria. So the challenge is that if you go all the way back to 2009, way before COVID, there were groups that looked at this in elite endurance athletes and the common cold, just routine infections, and they found edema and inflammation could be present in cardiac MRI. So if you look for it without a specific need or an intermediate pretest probability, you're going to find something because of the high sensitivity of MRI. 32 patients with cardiac symptoms a few years later in 2011 with H1N1, they found the same. Cardiac MRI, active inflammation, late gadolinium scar was identified in those 10 of 32, but at 3 months, all was resolved. So is it really important to do an MRI that quickly in a group that's probably going to do very well? So what we learned, I think, in the last year or so is that these challenges were that they were small groups. There were no control groups. A variety of late gadolinium enhancement patterns were noted, mostly at the RV insertion, and they were patchy. And we know we see this without COVID. We saw this in routine viruses. So it's a finding, but is it an important finding? So the utilization of cardiac MRI in the asymptomatic athlete should really be used with caution. We don't have a good handle on normal values for asymptomatic exercising young athletes, T1, T2, all these volume assessments. And we know that viruses can cause temporary scar and permanent scar. So if we find it, are there really outcomes that are associated with it? So if you look now at almost 6,000 patients we published between the ORCA data and the PRO data, we know that in general, SARS-CoV-2 in young athletes has a very low prevalence of cardiac involvement and an extremely low event rate. In fact, we've never had an athlete in the professional sports have a cardiac event related to it. So this data from 2021 in COVID, I think it was from Wisconsin, really helped me remind myself that if you look at a larger group, it sorts itself out. Almost 150 athletes, 2/3 of them male, ejection fractions were all normal, and mild increases in troponin in 1. The majority were asymptomatic, 2 of the 150 had MRI findings consistent with myocarditis, and one of the 2 had an elevated troponin. This was the one. If you can see this, clearly scar tissue consistent with myocarditis, a typical non-ischemic pattern, that increased T2 signal, for me, believable. 1 out of 145, I think that's real. This one was number 2, normal troponin value, and that smudgy kind of appearance. You can always get yourself in trouble in this RV insertion area. I'm not quite sure that's truly myocarditis. So then you're back to 0.6% with myocarditis in this group. That's what we found in the echo data. That's what we found in other viruses, and more consistent with what we would expect from this condition, and that we now know is correct. So we know this cautionary tale. If you go back to the early days of the evolution of ECG criteria, the high false positive rate early on led many folks down this pathway of abnormal ECG findings that led them to disqualification inappropriately. But as we studied it, we got better at it, we learned more about it, that false positive rate went way down, now in that 1 to 2% range. So we're really good at diagnosing those that are abnormal. What we do with it is still being sorted out, but we know this cautionary tale. Careful with applying an important tool like MRI, because of its sensitivity, you may lead yourself down a pathway where you can't get back out again. So here's an example of a 19-year-old African-American NCAA athlete, COVID positive, antibody positive, no symptoms, normal ECG, normal troponin, normal echo. A research CMR was performed. LV function normal, all of that increased trabeculation we talked about on the left and the right side. But when we got to late gadolinium enhancement, we had a problem. And he was sent to me for this finding. Is this important finding? Is he at high risk? Can he still play? Remember, we found this because we went looking for it in an asymptomatic athlete with everything else being normal. So this paper came out right around that same time, which helped me sort through this a little bit. This was a paper published in 2021 from Loda, and it looked at the features of non-ischemic late gadolinium enhancement, and it said in the dilateds and the HCMs, worse outcomes in those with late GAD compared to others, higher risk for sudden death compared to those with no late gadolinium enhancement. Those with LGE had a higher risk. We knew that. That's not news. What was important for me was that normal LV volumes, normal wall thickness, normal ejection fractions, they had a favorable association, whether they had late GAD or not. And that even if they had some late GAD, there was a low incidence of sudden cardiac death. So if the heart is otherwise normal and you find an incidental finding, the takeaway message they presented was that normal volumes and thickness and ejection fractions without features of a cardiomyopathy have a favorable long-term outcome. So not perfect for athletes, certainly not inclusive of athletes, but reassuring that if you find somebody with an incidental area of scar, it does not, so far, carry the same risk stratification we get from a dilated cardiomyopathy or those with suspected HCM. So cardiac MR and multimodality imaging is really important in athletes. Helps us identify wall thickness. It can include it or exclude it. Helps us identify the true LV and RV chamber size, and that in general, late gadolinium enhancement is not typical in athletes and quite rare under the age of 40. So if you find it, it really requires more diligence and follow-up compared to those who do not have it. It's an important tool for athletes, especially those with unexplained findings, those gray zone, borderline LV and RV findings. It's rarely the first step we go to, but it does offer a deep dive into how to better evaluate athletes. Thank you for my invitation. I'm happy to take questions.
Thank you so much. That was, I think, an amazing lecture, and I love the combination of imaging that you're describing. And I think, so if people have questions, please put in the Q&A and we'll go through them. I think it's very troublesome when you do a research study and you have findings that for a patient you wouldn't have done it clinically, and what do you do with that afterwards? So
Agreed.
it's troublesome to make reports for those studies, right?
Agreed. And I think that the old days, right, where we would mostly disqualify athletes compared to now there's an expectation that we can do better than that, that we can be more comprehensive, that we can try and identify who might be safe and who's not safe, and then have that risk assessment for them, and then hopefully better educate them on what to do. And I love what you said. It reminds me of what we were all taught years ago, right? We were training about Bayes' theorem, and that it's really important to have a reason for ordering tests, because although ordering more tests early in your career feels like the right thing to do, in many times it is not, and it ends up leading down a different risk and a challenge for you, for sure.
I guess going to as a first question similar to that, and it's something that with CT that we didn't talk about, but some of these patients or athletes that are in their 40s or older athletes, what do you do for prevention? For example, do you ever use calcium score in these patients? That's an area that has been very controversial as well.
Yeah, so I should come back and do that. I have a lecture on the utility on how I use coronary calcium scoring, and because it's so readily available, many athletes come to me with a coronary artery calcium score. And the first thing I try and find out is, one, were they on a statin beforehand or not? Because as you know, the statins will actually increase the calcium score. So if some of them want to serially follow it, and they have a CAC from 5 years ago and it increased now, and they've been on a statin and are really scared, holy cow, the calcium score is rising, am I in trouble? So the answer to that is no, right? It's probably statin related. You're maybe stabilizing those plaques. But there's data from UT Southwestern and Dallas that shows that although we do find increased calcium scores in athletes, it turns out that if you exercise, you can actually reduce your risk the more you exercise. So the more, even if you have an elevated calcium score, the more you exercise, the lower the value ends up. The lower your risk goes over time. It never gets to as good as zero, right? It's still a zero calcium score has the most powerful prognostic capability. And if you look at most of the papers that are being published, more than half, 60% of athletes actually have a normal calcium score. So it still exercises medicine. It absolutely reduces your cardiovascular risk. But if you find a calcium score, it's not a reason to restrict athletes. It's a reason to risk stratify them and then potentially allow them to exercise even more to lower their risk even further. So I definitely do not disqualify folks based on an abnormal CAC.
Great, thank you very much. We have a question from Danny Sims, one of our advanced heart failure cardiologists. Thank you for the talk. You mentioned the role of detraining for pregnant women giving birth, and the non-compaction goes away when the volume load goes away. Is there still a role for unclear cases having athletes stop exercising, training, and re-imaging, or has advanced imaging and genetic testing made this unnecessary?
It's a great question. So I will separate it and say that in those with wall thickness, so wall thickness of 18 millimeters, we just haven't seen that the value is what we hoped it would be or what was previously proposed. So in those with HCM, if they have not been able to wrap their hands around the fact that they have a new diagnosis, I will often offer it to them and say, let's give you 3 months off and re-image and see if we can make some changes as a physiologic adaptation. Most of the time that is not happening. I've just not seen any importance. So I don't use it very much. And in the current era, thank goodness, we've moved beyond this dichotomous, you can't play if you have this, and you can play if you don't have it. We've moved into better risk stratification. We didn't talk about this, but I've been talking about this the last year or so. In those with suspected cardiovascular disease, we're better than that. We're better than just saying you're dichotomous and you're out. In fact, we should do shared decision-making. It's part of the guidelines, and it has changed our need to get someone from a 16 millimeter thick wall down to a 14 so that, they're no longer at risk. We know that's not true, right? But it makes us feel better if they're under that 15 millimeter range. So instead, what I tell that group is, I'm happy to detrain you, but here's what we know. Your monitor is normal, your stress was normal, you don't have scar, your wall thickness is 17 millimeters, you're already in a low risk category. Let's talk about the things you may be able to do even with that diagnosis. So I think we've moved a little bit beyond that for HCM for sure. For the dilated ventricles, I have moved away from it as well, although the data is a little better in that. I find that if the ventricles are big and I detrain them, they do go back to a normal value more often than not, although not every time. Instead, I use a lot of stress echo and I look for augmentation of the left ventricle. Most of them don't want to take 3 months off, so I run them. I put them on a treadmill and I run them for as much, treadmill them with sprints and variation on the treadmill and try and get them to go as long as we can. And if the ventricle augments normally, the ejection fraction comes down, the stroke volume goes up. To me, that's reassuring that it's actually more of an athletic change than not.
Great, thank you very much. We have a question from one of our fellows, Saul Rios. He says, thank you for this interesting talk. Have you found that athletes often have an abnormal mitral flow Doppler pattern, but normal tissue Doppler velocities?
So in general, I would say no, we've not seen that very much. Usually you have a normal inflow with normal tissue Doppler. However, the strength athletes can often have some abnormal mitral inflow because the ventricles are a little bit thicker. So in those big powerlifting athletes that have hypertrophy related to that, sometimes we'll see a variation in the mitral inflow pattern with a normal tissue Doppler or low normal tissue Doppler. If the EE prime ratio is normal, then that's reassuring to me. This is an athlete, but I want to make sure they're truly an athlete. Many times people fancy themselves athletes and are no longer athletes. I had an athlete who came to see me at 33 and she said, well, I think I have an athletic heart. And I said, well, great. What sport do you play? And she said, well, I haven't played since high school. So that's a different thing. So after about 6 to 8 weeks, your heart no longer thinks you're an athlete any longer. So I think mitral inflow pattern with a normal tissue Doppler would be unusual.
Great, thank you very much. From Mark Menegos, he says, wonderful talk, thank you. From Paulo Schwartzman, he says, great lecture, Matthew. Do you think there is a role for tagging for visual assessment and to differentiate LV hypertrophy to hypertrophic cardiomyopathy?
You're talking about MRI tagging, right?
MRI tagging, I think, yeah.
I think there could be. I haven't been able to do it well enough. We tried this when I was still at Mayo. I tried this as a fellow, and we just couldn't measure them reproducible. It wasn't reproducible enough at the time for us to distinguish it. But much like we're doing in diastolic function, I'd love to be able to do that with tagging, and happy to collaborate if you're going to end up doing that. But it would be a useful next step. I think tagging could have some value. We don't use a lot of tagging anymore with T1 and T2 and extracellular volume. We're just not using a lot of tagging any longer.
I loved how you showed on the strain data related to that, the focal changes, local changes, and difference. If we just focus on the global longitudinal strain only, we may be missing some information. So maybe the tagging could play a role in some of this.
I agree. And what's interesting is that I've come full circle on this. 10 years ago, I said strain doesn't help, right? There's too much overlap, it doesn't help. And then I came with, abnormal strain values may help. I've seen this now enough. And now the global longitudinal strain seems to be least helpful for me, the bullseye pattern. I'm back to looking at the images and looking for that differential. Seems to be the most helpful for me.
We have a question from Mark Menegos now. It's this question about following a marathon runner in his 50s with bicuspid aortic valve and moderate AI. I followed his echo for decades, no change in dimensions and no symptoms. Should we have a baseline CMR?
So I would, and I think for a couple of reasons. One, I think it'll help you with the valve disease for sure. I still think we're learning more about volume assessment by MRI with especially with valvular heart disease. So I think it's really important to get a baseline for that group, this individual. And now you're discerning over time, at some point, that AI may be, I think I heard you say moderate AI, right? So eventually that AI is going to become severe. And that now you've got yourself a real problem, right? Is this the athlete change that and the ventricle's big, or are we going to use standard cutoffs? If his ventricle's really big and the AI is now severe, is it because of the AI or is it because he's become more athletic? I have an athlete like that who's a young track athlete. And during his collegiate years, we attributed the whole thing to him being an athlete. His ventricle was huge and he had no symptoms and was doing very well. And he had really moderate to severe AI. It was a lot. He did not want surgery. So we continued to restratify him. He did very well. But now 2 years after no longer being a collegiate athlete, his ventricle remains big and the AI is still severe, of course. So we're in this conundrum, and it's really valuable for me to have those sequential MRIs every year or two as a much better way to quantitate the volume, the ventricle size, what the stroke volume looks like. So I typically would do a baseline.
And on top of that, this is a marathon runner, but you deal with NBA players, right? All the volume indexes that we use are probably not valid in that group, right?
Agreed. Now, that's exactly right. And we do have some echo guidance from Engel that helped us for sizes, but the stakes are really high in that group, right? So you're taking away someone's ability to make money, but you're also taking away their ability to, just sort of do the things they love to do. And so there are stakes on both sides. If you overcall it, you've ruined your career. If you undercall it, then you're putting the team and the player at risk. So all of that requires some due diligence for sure.
So a question from David Borchheimer, our clinical cardiology director. He says, thank you for an outstanding lecture. What are your thoughts regarding routine pre-screening for high school athletes?
Oh boy. Well, so thank you for this non-controversial question. So this is important to me, and I'm happy to come back in terms of risk stratification for athletes for cardiovascular disease. A couple of questions have really been around that and how we handle that. That's what this question's all about, right? So should we pre-screen athletes with ECG? There are big problems with this. The first is that do you have the ability to perform it, right? What's the cost associated with it? Can you do it well? Can it be reproducible? What do you do with the athlete ECGs to screen them? Who interprets them? And what you do with the interpretation for sure is important. There are challenges with interpretation. There are challenges with downstream holdouts. So if you hold somebody out I had a swimmer who flew down to see me for incomplete right bundle branch block. Right, they were uncomfortable. Thank goodness his dad had a lot of money and flew him down, or his mom. They flew him down for an evaluation in 2 days. The local cardiologist was almost 8 weeks out. Well, by the time that happens, swimming season's over. So there's not much left. So you have to have a really good plan for interpreting ECGs and how to manage those ECGs. And then in the current era, with risk stratification being the way it is, I want to know what we're going to do with those ECGs. So if the idea is to disqualify athletes, then I'm not in, right? I have no interest in looking for athletes to disqualify them, especially because Black athletes have more abnormal ECGs than others. So we're selecting for that group to disqualify. I'm not a fan. But if we're looking to risk stratify them and to follow them over time, I'm all in. We also don't know about interval follow-ups. Is a ECG at 15 good for 1 year, 2 years, 4 years? We don't know. In Major League Soccer, we do them every other year, although there's no data for that either. So we need to look into that. There's a lot to be done with when to follow up. That study from Sanjay Sharma and his group in Europe showed that we're going to miss stuff. If you do an ECG, you're going to miss stuff and you could potentially put kids at risk. Yeah. So I see this follow-up. Do I ECG my own children? Great question. And I can tell you I have 5, and I have all are high school athletes and above. 2 of them are collegiate athletes. They've never had an ECG. 0.
I love the point I think that you're bringing on the change in paradigm from like disqualifying to a risk stratification and a shared decision making. Is that okay with all leagues? So how do leagues respond to that?
So far, that seems to be the case. That at least with the professional leagues, that's the case. The collegiate athletes are different. And what I tell folks is that if you're in a place that is uncomfortable with managing you with a mild dilated ventricle or a moderately dilated ventricle or with mild HCM, then go to another school, right? That's okay. You want to go to a place who is comfortable with it, and that there are resources to handle that individual. But what I don't want is athletes not telling us stuff. And they can block it, right? They can say, this is a civil liberty. I don't want an ECG. You're just looking to disqualify me. And then we're into this really challenging place where we were 25 years ago, where we have no idea what's happening with athletes. And the undiagnosed HCM is the one that I lose sleep over, not over the diagnosed one. So if I don't know that you're at risk and you pass out, that's a different piece for me than if I know that you're at risk. So I don't want athletes refusing to get cardiac assessment, because then we're all at risk. The athlete, the leagues, the institutions, and the providers. And remember, the cardiologist is at home watching the game on TV. Those poor ATCs and the team docs, they're there. So it's part of our job to help risk stratify them for their sake.
That's awesome. Thank you for an amazing lecture. I really enjoyed it, and I'm sure everyone else in the audience did as well. So I'm looking forward to have you here in person, hopefully in the future. Maybe you can talk about all the other subjects that came up.
That would be terrific. I'm happy to come back. And again, hopefully we're all out of this soon, but maybe in person in the future, we'll talk about those controversial topics for ECGs and for managing athletes. Thank you for the invitation.